Well, thank you, Patrick, and thank you very much for this very kind invitation to this meeting. It's a pleasure for me to try to overview with you the state of the art of transcatheter aortic valve implantation and not replacement. This is why I use the acronym of TAVI instead of TAVR. And I will also give you the perspective of this technology in the future. I would like to start by a slide that could be finally my conclusion today. I had the pleasure of writing an editorial for Eurointervention last year for the commemoration of the 15 years anniversary of TAVI, and I stated that it can be predicted that within 5 years the indication for surgical valve replacement will be limited to patients who are not optimal candidate to TAVI. 1 year later, I have not a word to change to this statement. You know, in the early 90s, I had a dream. The dream was to replace the aortic valve using a transcatheter balloon expandable valve inserted within the diseased valve without removing the calcific aortic valve, using usual cardiac catheterization techniques with local anesthesia. It was a dream which was thought to be totally crazy by all the experts. Actually, in April 16, 2002, after 15 years of research and the creation of a startup that was called Percutaneous Valve Technology with Martin Leon and 2 engineers working for Johnson & Johnson, we made the first balloon expandable valve, and we could implant it for the first time in a patient. And this patient had all the contraindication that we would respect today for percutaneous valve implantation. He was a dying patient with 12% ejection fraction, a thrombus in the left ventricle, and he had the 2 femoral arteries blocked in such a way that the cherry on the cake, I had to implant this first valve using the transseptal approach, which was not at all planned. The conclusion of this first amazing case was that non-surgical implantation of a prosthetic heart valve can be successfully achieved with immediate and mid-term hemodynamic and clinical improvement. That was great, but what now? What now? We had the possibility of doing a series of patients, all in compassionate basis, all very, very sick patients, using only the complex transseptal approach for a question of regulation in France. So I had to use the same technique used for the first patient. And using this approach with the first percutaneous valve made by PVT, Percutaneous Valve Technology, we did a first series of 40 compassionate cases in 2 series called HighRisk and Recast. And the technique was quite successful with 85% of success, and start spreading in Europe and in the United States with the first TAVI case done in Detroit in 2004. Interestingly, this was a premature minimalist adventure, as we say now, using only local anesthesia, no transesophageal echo, pure percutaneous approach, manual compression of femoral vein and angiosyn on the contralateral femoral artery with no procedural complications. We had several lessons from this first series of patients concerning the feasibility of TAVI, the accuracy of valve placement, the lack of embolization of the valve, no coronary occlusion, no mitral regurgitation, no AV block, optimal valvular function, excellent hemodynamics, but we had the paravalvular leak in 25% of the cases because we had only a 23 millimeter valve available, single size. What next? Next came the I just wanted to show you this case because regularly I don't show it, but it's very interesting. It's in September 2003, the patient number 10 of our series had the first-in-man plan retrograde TAVI. So this was necessary because the patient who was really very sick had also a mitral stenosis, so we could not use transseptal approach. And this transfemoral route, retrograde, was very successful, as you can see here on the screen. And you can see the patients 5 years later, and she died at 6 years of a breast cancer. So this was very encouraging, and it was a first and good vision of the future of TAVI where we are today. In 2004, TAVI enters a new era by the acquisition of percutaneous valve technology by Edwards Life Sciences, and they design new valve, new delivery system, and new approaches. The Edwards Sapien valve had the advantage of being made in two sizes, 23 and 26 millimeter, that changed our life and decreased tremendously the rate of paravalvular regurgitation. And we could develop the technique of transfemoral approach in regular basis and the transapical approach for the patients who had no coronary arteries available. The Edwards Life Science pathway has been absolutely remarkable, with hundreds and hundreds of patients included in a feasibility trial and larger series with follow-up between 2005 and 2007 in Europe and in the United States, leading to the CE mark in 2007, and then they moved to evidence-based trial. Remarkably, you will understand that during 8 years, we have been carefully moving from compassionate cases to high-risk patients only, at the opposite of what is done in general in interventional cardiology, for example, with PCI, where it is normal to start with easy cases to finish with more severe cases. So the fact that we could be doing this procedure successfully in this kind of patients as a start is absolutely unbelievable. At this stage, it means in 2017, for the 5th anniversary of TAVI, no one, even me, could have predicted the rapid TAVI technology evolution, the refinements and simplification of the procedure, the spectacular amount of TAVI scientific evidences, the striking acceptance of the procedure by the medical community, and the growth of TAVI worldwide. So where are we today? Most of our knowledge concerning TAVI has been coming from the experience with two valves, the Sapien balloon expandable valve, which has been modified with time, but which remains almost the same that we were using at the beginning, and the Medtronic valve, core valve, with the last generation of Evolut R. It's amazing that today we are reaching more than 350,000 procedures in 65 countries. We have 1,400 centers open, validated for TAVI, 600 centers in the United States, and we are expecting a growth of not 40%, but 20% per year. You can see here on this slide the estimated US TAVI growth, for example. We are today with 67,000 patients in 1 year, and they are planning to reach 164,000 patients in 2025, 7 years from now. The market will increase by 2.5 between now and 25. In the US, in 2025, it is expected that 75% of all valve replacement will be done using transcatheter aortic valve implantation. This success has been made with the influence, the extraordinary partnership of the industry, and you can see here the number of valves which are under investigation, validated by the CE marked in Europe. And we have here 17 valves already validated, but the two leading valves remains absolutely the Medtronic self-expanding valve and the balloon expanding valve from Edwards. And we have many other valves under investigation. What is the reason of this success? Obviously, the quality of the results, which are absolutely amazing today, and also the considerable procedural simplification. Excellent hemodynamics, as you can see here on the left, And transfemoral TAVI, it means pure percutaneous technique, is feasible today in more than 90% of the cases, which is absolutely unbelievable. This is done under local anesthesia, without sternotomy, no extracorporeal circulation. It offers an early discharge and no rehabilitation program after the valve has been placed. Today we can say that TAVI can be performed as a stent-like procedure, using in the vast majority of patients the so-called minimalist approach, using local anesthesia, closure devices, no transesophageal echo, and early discharge. You can see here an example of the Edwards valve implantation as it is done today. The procedural duration is below 45 minutes from skin to skin, and more than 70% of the patients can be discharged before day 3. So you can understand why this technique is so well accepted by the medical community. Also, the success relies on the scientific evidences. I have made a selection of slides here, but the first extraordinary news was the results of the Partner 1 trial in the United States. The Partner 1 trial, and here the branch of TAVI compared to medical treatment alone in patients who are not surgical candidates, was extremely positive, with 25% reduction in mortality at 1 year, and with lasting similar results up to 5 years. This showed that TAVI is superior to medical treatment, and today all the patients who cannot for any reason be operated on by the surgeons, who are not surgical candidates, must have TAVI as the optimal option. TAVI versus surgery in high-risk patients was the second very important evidence-based study, the Partner 1A trial in 2012, showing that the results on all mortality was similar in the TAVI branch and in the surgical branch. So this was extremely encouraging, and we started to think that in high surgical risk patients, we can offer TAVI with similar results than a valve replacement. And in 2014, CoreValve published the same series showing even better results with TAVI than surgery in these high surgical risk patients. So the conclusion is TAVI is equal or superior to surgery in high surgical risk patients. What about the hemodynamics offered by the valves? The hemodynamic of the percutaneous valve in comparison to the bioprosthetic valves are absolutely similar gradient up to 5 years. In the CoreValve group, it has been shown that the results concerning the aortic valve area and the decrease in gradient was even better after implantation of the percutaneous valve than after surgical valve replacement. So TAVI equals surgery at 5 years on this hemodynamic results. What about today the TAVI in intermediate risk patients? You have here the results of the Partner 2 trial, which was done with the Edwards XT valve, which is not the last generation of valve, showing the similar rate of all-cause mortality between TAVI and surgery, which was something really expected but not sure at all. And the SURTAVI trial in 2017 with the CoreValve showed exactly the same thing at 2 years. The conclusion is TAVI is comparable to surgery at 2 years. If we use the last generation balloon expandable valve, which is called the SAPIEN valve, much better with less paravalvular leak, the results of TAVI on the mortality is even superior to surgical valve replacement. And thus, if you observe these two curves, you will conclude that this is totally due to the procedure applied, different procedure, transcatheter, percutaneous approach, local anesthesia, or surgery with open chest surgery, extracorporeal circulation, etc. So the partner 2-3 concluded that with the balloon expandable valve, the SAPIEN 3, the results are even superior to surgery if we use the transfemoral approach. Severe symptomatic aortic stenosis, we have here the most recent European and US updated recommendation. As you can see here, in Europe, in the patients with intermediate or high risk, the classification is 1B. It means that we have absolutely all possibility of undergoing transcatheter aortic valve implantation in patients with intermediate risk. You have below the classifications of the AHA-ACC guidelines in the United States, where TAVI remains in the classification 2B. What next? Is it possible to think, using this technology, proposing TAVI to all the patients with aortic stenosis, whatever the risk? We have very few data today, except the Notion 2 trial, which is a monocentric study from north of Europe. I will show you the results, which are extremely encouraging, but we have 4 ongoing randomized trials of TAVI versus surgery in all comers, low-risk patients. We have partner 3 with a balloon expandable valve. We have the same study with a core valve. We have the Notion 2, a little more data from the Nordic study, and the UK trial ongoing. If we have a look on the Notion study, it's extremely interesting to see that on a relatively limited amount of patients, 280, the results on mortality, strokes, and so on are similar in the two groups, TAVI and surgery, in those patients who are all comers. The results on the hemodynamics appears better with a transaortic valve than with a surgical valve. Very recently at the TCT meeting, the same results were published at 5 years. And again, as you can see here, the curves, mortality and stroke, are absolutely identical between surgery and transcatheter aortic valve replacement. But the hemodynamics are significantly better after a transcatheter aortic valve replacement. We have some potential questions before further expanding the TAVI to the low-risk patients, and these questions relies on the durability of the transcatheter valve, which is not very well known, the pacemaker rate, and the access to coronary arteries after the valve has been implanted. We can already foresee that we will take the decision with the heart team, but also with the patients, and age will be the key of the discussion in low-risk patients. First of all, the long-term durability. We have relatively few data concerning the long-term durability because beyond 5 years, most of the patients were dead because of the severity of the criteria of inclusion. They were all high-risk patients for the most, but we have 3 series of patients recently published, including our series in Rouen. We have been assessing almost 380 patients who had survived TAVI for more than 5 years. And these results show that if we use a standardized definition that we have today on structural valve deterioration, which means an increase of gradient by more than 20 millimeters of mercury from one exam to the other, severe aortic insufficiency, and so on, we have only 3.2% of patients with structural valve deterioration, and among these patients in our series we had only 2 patients who needed reoperation. The same comparable results are coming from Deutsch, published this year, and by Holly. And you can see here that 7 years structural valve deterioration is between 0 and 14.9%, with the need for reoperation in only 3.3%. So these results are limited, but they are quite reassuring. Age will be the key in the discussion if we want to propose TAVI to low-risk patients. In low-risk elderly patients, it means more than 75 years of age, we have strong advantages of TAVI over surgery. First of all, the fact that it's a less invasive procedure, requiring only local anesthesia, short hospital stay, and no rehabilitation. Today, the picture that you have here, patients leaving the hospital at day 2 after valve implantation, 78 years old, is absolutely usual. The risk of transfemoral TAVI in this population are always the same. First of all, the rate of pacemaker, but we would say that it's less an issue at this age, and this is not rare after surgery neither. The durability, it's less an issue in this population because of the limited life expectancy, and the treatment of systolic valve dysfunction could be a valve-in-valve as an option, or even surgery. And the access to coronary arteries after valve-in-valve, for example, may be a problem, but it's not an issue in more than 50% of the patients who have normal coronary arteries. The main question is what to do in low-risk younger patients, for example, less than 70, 75 years of age. In this population, transfemoral TAVI offers the same advantages. I say transfemoral because now it's done, as I said, in 90% of the cases. It's a far less invasive procedure, short hospital stay, and immediate return to normal active life, which is quite important for this younger population. We will have the results of the randomized trial, but it's possible that pacemaker will be an issue. We will have more pacemaker after valve implantation, percutaneous valve implantation than after surgery. This is something that is in the pipeline, but we will see. The durability might be an issue, but in this population of younger patients, surgical valve replacement might remain an option without any limitation, a secondary option in case of early valve dysfunction. The access to coronary arteries, again, may be a problem in this population, but only in coronary patients. Another question is the rate of bicuspid valve in this younger population, where bicuspid valve can be observed in 60% of the cases. Is it an issue? We don't know yet, but the first results of TAVI in bicuspid valve are really encouraging. I think we'll have part of this conclusion in the next session of the American College of Cardiology meeting in 2019. In the younger low-risk population, in the absence of anatomical contraindications to transfemoral TAVI, a well-informed patient refusing surgery might have in the next future the deliberate choice of undergoing transfemoral TAVI, keeping in mind that surgical valve replacement remains an option, either in emergency or planned in case of unsatisfactory result or valve failure on follow-up. Today, when we try to imagine what could be the future of TAVI, we have also many other indications, potential indications. First of all, the valve-in-valve for the treatment of bioprosthetic heart valve failure, which is with a registry which shows excellent results. The bicuspid valve is assessed now in a multi-center US bicuspid aortic valve registry. We have the possibility of implanting, we are assessing the possibility and the interest of implanting a valve in severe asymptomatic aortic stenosis, and we have today a randomized trial in the United States. The possibility of implanting the valve in the case of moderate aortic stenosis with heart failure, This is also under investigation in UNLO trial, international, randomized, and also the high-risk aortic regurgitation population, where TAVI may have some indications, and the role of TAVI in aortic stenosis with concomitant disease like other valvulopathies of coronary artery disease and the low-flow, low-gradient categories of patients. 15 years after the first in man, TAVI might become the default strategy for a vast majority of aortic stenosis patients because of procedural advantage which clearly outweigh the potential limitation, which are durability, pacemaker, and access to coronary arteries. And again, TAVI does not preclude from secondary surgery. If I can give you my personal view on the future of TAVI, you have here in 2014, TAVI appeared in the guidelines in Europe and in the United States for high-risk inoperable patients. And Partner 2 led to the appearance of TAVI in the new guidelines for intermediate risk patients. This is where we are. There is no doubt the minimalist transfemoral TAVI strategy will grow, reaching today already 90% of all the TAVI cases. We are expecting some new guidelines after the results of the Partner 3 and other randomized trial in low-risk patients. So this is something that should come in 2019 or 20. We will have to revisit the heart team and the scoring system, taking into account that in 2020 age will be the major factor and the informed patient will be part of the heart team decision. I guess that in the future surgery will remain the best indications for younger patients, for example below 65 years of age, in some cases of calcific bicuspid valve, and in cases of massively calcific aortic stenosis, where in general TAVI didn't give the optimal results. The issues will be definitely the durability of the transcatheter valve, the rate of pacemaker, of stroke, the reaccess to coronary arteries, and the post-TAVI medical strategy. The expectations are that the results of TAVI should become comparable to surgical valve replacement beyond 10 years. This is what I hope, and I am quite sure that we will reach this step. Thank you very much for your attention.